Well, there were two goals of the MSToPS trial. First was to meet this unmet need in identifying undiagnosed atrial fibrillation, where current guidelines recommend just opportunistic screening of individuals for atrial fibrillation. So basically somebody comes into a doctor's office for an appointment and you feel a pulse. And we felt that that left a lot of people undiagnosed. And that's important because atrial fibrillation is one of the major risk factors for a stroke. It increases your risk of stroke 5-fold. But if you can identify somebody with atrial fibrillation before they have a stroke, anticoagulant therapy decreases that risk by almost 70%. And really there's almost nothing else that we do that we screen for, whether it be mammography or prostate-specific antigen prostate cancer, where we can be so effective at preventing a bad outcome once we identify something. The second big objective was to show that we could do a direct-to-participant digital clinical trial, that we could break the model of a multi-center randomized trial, but we were able to allow people to enroll directly by directly inviting those individuals and then to carry out a very pragmatic study. So actually the whole MSToPS trial was based on using several different digital technologies. And first that started by using a very large database within the Aetna health plan to identify people who met the inclusion-exclusion criteria. They were then driven to, or we sent them an email to invite them to a website, and if they were interested, that drove them to a website that gave detailed information about the study, had a short video describing the study. And then if people were still interested, they were walked through a digital step-by-step informed consent that explained every aspect of it. And then finally, if they still were interested, they signed the consent. Then we sent them the wearable sensor device. It was an ECG patch named the Zeo patch made by a company, iRhythm. The nice thing about this patch is that individuals just self-applied it. It was sent to them. They took off the adhesive. They put it on their chest and wore it for up to 14 days. Then they were done. They put it in a pre-addressed box and dropped it in the mail, and they were done. It was a somewhat complicated design, but it was a randomized clinical trial that was embedded within a prospective observational cohort study. So what we did is we reached out for people who actively consented. They were randomized to either immediate monitoring or delayed monitoring. Immediate, they got the Zeo patch within 2 weeks of consenting. If they were in delayed, they got the Zeo patch 4 months later. And then the initial analysis was at the 4-month difference. So you had the delayed cohort who hadn't been monitored at all. So we just looked at their routine care AFib diagnosis versus the monitored. And the reason we had the randomized design for this is we wanted to make sure just inviting people to be screened for atrial fibrillation didn't trigger them to go out and look for a diagnosis of atrial fibrillation or make them go to their doctor and say, oh, why does my health insurer think I might have atrial fibrillation? Then once both groups were monitored, we compared them to a age, sex, and CHA2DS2-VASc score matched control group. And that was a 2-to-1 in the control group based on power calculations for a 3-year follow-up, which is still going. And so essentially at the end of a year, we could compare 1,755 individuals who are actively monitored for AFib to 3,000 and about 500 matched controls to look at the difference in AFib rates, but also to look at how did ECG monitoring affect healthcare resource utilization and how did it affect outcomes. So probably not surprisingly, in the primary 4-month endpoint, we found that ECG monitoring was associated with a 9-fold increase in the risk of, or in the likelihood of identifying atrial fibrillation relative to routine care. At the 1-year point, where we looked at the combined actively monitoring versus the controls, and with longer time for it to accrue more routine care, it was a 3-fold increase. So still a remarkable and very statistically significant increase in the diagnosis of atrial fibrillation. We found that that also drove more primary care and cardiology outpatient visits, as well as more pacemaker placements. but no excess of inpatient hospitalizations. Interestingly, when we looked at just those individuals who were diagnosed with atrial fibrillation, in the clinical and the control cohort, they had almost a 6-fold higher rate of stroke compared to the actively monitored group, 3-fold higher myocardial infarction rate, and twice the hospitalization and ER visit rate. Well, this was really designed for a population-based approach, and it offers a lot of unique information about atrial fibrillation we didn't know before. It very much supports the idea that opportunistic screening is going to miss a whole lot of, in fact, the vast majority of asymptomatic atrial fibrillation. And the reason is that we found that most people had very low burdens of atrial fibrillation, so that most people were in atrial fibrillation actually less than 1% of the time. And so 99% of the time, somebody is not going to be in atrial fibrillation, and if you just screen them for a couple seconds, you're going to miss that. But more importantly, what designed as a pragmatic trial, we really designed this to be continued to follow on within systems like Aetna and other health insurers, maybe large healthcare systems, where they could identify high-risk individuals to screen early, and showing that with a patch, such as the Zio patch, that they're going to effectively diagnose a high-risk cohort. So what we're hoping in follow-up is to take everything we learned in MSToPS, be able to identify, reach out to a higher risk cohort, be able to have them wear the patch, communicate with them the results more directly, and refine our understanding, including, we hope, including a genetic risk score to really identify those at highest risk. And each thing we build on is going to make it more and more clinically applicable in large populations for screening.